नमस्ते बिटिया, हमेशा खुश रहो बिटिया. A very good morning to you all. Myself, JVN Dr. Ravi Jain, Assistant Professor, Department of Practice of Medicine and Faculty of Homeopathic Science at JAYOTI VIDYAPEETH Women's University, Jaipur. In today's lecture, we are going to continue with the series of the diseases of kidney or the renal system. In the last lecture, we have discussed about acute renal failure. In today's lecture, we are going to discuss about chronic renal failure or the chronic kidney disease. So let's start with the chronic kidney disease or the chronic renal failure. What is chronic renal failure? In the acute renal failure, we had discussed that it was a reversible process. But in case of chronic kidney disease, it is basically an irreversible deterioration of the renal functions. So there is irreversible deterioration of the renal function that classically develops over a period of years. So there is deterioration of the renal function and it is developing over years. Initially, it is manifested as biochemical abnormality. So there is biochemical abnormality with the loss of excretory functions. There is loss of metabolic functions and endocrine functions. So in kidney, there is loss of excretory function, there is loss of metabolic function, and also there is loss of endocrine functions of the kidneys. That is leading to the clinical symptoms and signs of renal failure that is referred to as uremia. So there is loss of excretory, metabolic, and endocrine functions of the kidneys that is leading to the clinical symptoms and signs of renal failure, and it is referred to as uremia. The normal GFR, that is normal glomerular filtration rate, is 120 plus minus 25 ml per minute per 1.73 meter square. What happens if there is uremia? Uremia means increased urea in the blood. In case of uremic features, the patient will have the symptoms of anorexia. That means the patient will not be having any desire to eat. There will be nausea and vomiting. So the patient will have anorexia, nausea, and vomiting. It is followed by the anorexia, nausea, and vomiting is followed by the feeling of drowsiness. There is drowsiness, apathy, confusion, and muscle twitching. So there are first of all features of anorexia, nausea, vomiting, and it is followed by drowsiness, apathy, confusion, and muscle twitching. There are features of hiccups, fits, and coma. So the uremic features includes anorexia, nausea, and vomiting, and it is followed by the drowsiness, apathy, confusion with muscle twitching. There are hiccups, fits, and coma. Now, stages of chronic renal disease. There are different stages of chronic renal diseases. There are basically 5 stages based on the functioning, the loss of functioning and the loss of excretory, metabolic, and endocrine function that we see in case of chronic kidney disease. So number 1, we have stage 1. Stage 1 is characterized by the kidney damage with normal or high GFR that is greater than 90. So if there is kidney damage and the normal or high GFR is present, that is greater than 90, it is known as stage 1. In stage 2, there is kidney damage with slightly low GFR. If the GFR is between 60 to 89, it is known as stage 2. So in stage 1, we have kidney damage or the normal or high GFR that is greater than 90. In stage 2, we have kidney damage with slightly slow GFR that is 60 to 89. In stage 3, we have moderately low GFR that is between 30 to 59. In stage 4, we have severe low GFR, that is between 15 to 29. And in stage 5, there is total kidney failure with GFR less than 50. So we have stage 1, 2, 3, 4, and 5. In stage 1, there is kidney damage with a normal GFR that is greater than 90. Stage 2, we have kidney damage with slightly low GFR that is between 60 to 89. In stage 3, we have moderately low GFR that is between 30 to 59. In stage 4, we have severe low GFR that is between 15 to 29. And in stage 5, we have kidney failure that is less than 15. Now, what are the common causes for chronic renal failure? So chronic kidney failure or chronic renal failure, the most common causes includes any condition which destroys the normal structure and functioning of the kidney. So any of the condition that is destroying the structure and function of the kidney will be responsible for development of chronic renal failure. There are different causes which includes congenital and inherited causes, which includes polycystic kidney disease and Alport syndrome. So any of the disease that is destroying the normal structure and functioning of the kidney is responsible for development of chronic renal failure. There are various congenital and inherited causes, which includes polycystic kidney disease, Alport syndrome. There are various diseases related to the renal artery stenosis. So we have renal artery stenosis, we have hypertension, we have glomerular diseases with intestinal diseases. We also have various systemic inflammatory diseases, that is SLE and vasculitis. Also have diabetes mellitus and unknown causes. So the common causes includes any of the disease that destroys the normal architecture and functioning, the structure and functioning of the kidneys. The congenital and inherited causes includes the polycystic kidney disease and Alport syndrome. We have renal artery stenosis, we have hypertension, glomerular diseases, interstitial diseases, systemic inflammatory disease, which includes SLE and vasculitis. We have diabetes mellitus and unknown causes. Next, we come to the Alport syndrome. What is Alport syndrome? Alport syndrome affects the adults. And there are autosomal recessive diseases which arises from the mutation or deletion of the genes on the X chromosome. So Alport syndrome affects the adults and autosomal recessive disease. It arises from the mutation or deletion of the gene X chromosome, that is COL4A5, which encodes the type 4 collagen. There is accumulation of abnormal collagen that result in progressive degeneration of the granular basement membrane. The affected patient progress from hematuria to end-stage renal failure in the late teens or 20s. So there is accumulation of the abnormal collagen that is resulting in the progressive degeneration of glomerular basement membrane. The affected patient progressed from hematuria to end-stage renal failure in the late teens and 20s, and it is associated with sensorineural deafness and ocular abnormalities. Next, we come to the pathogenesis of chronic kidney disease. In the pathogenesis, there is disturbance of water, electrolyte, and acid-base balance. So we have disturbances in the water, we have disturbance in the electrolytes and acid-base balance that contribute to the clinical picture. The exact pathogenesis is unknown. There is exact pathogenesis that is unknown. There are many substances in abnormal concentration in the plasma. And uremia is caused by accumulation of intermediary products of metabolism. So in the pathogenesis, we have disturbance in the water, electrolyte, and acid-base balance that contributes to the clinical picture. The exact pathogenesis is unknown. And there are many substances in the abnormal concentration in plasma. And uremia is caused by the accumulation of intermediary products of metabolism. Now we come to the clinical features of CKD, or the chronic kidney disease. Whenever a patient of chronic kidney disease is coming to us, What are the clinical features or the common symptoms that the patient will present to us? There will be raised blood urea creatinine. So whenever a patient of chronic kidney disease is coming to us, there will be raised blood urea and creatinine level. There will be hypertension, proteinuria, and anemia. So there will be a condition of raised blood urea creatinine. The patient blood pressure will be raised, and that is known as hypertension. There will be a protein loss with the urine, that is known as proteinuria, and anemia. The disease is slow progressive and the patient are asymptomatic until the GFR falls below 30 ml per minute per 1.73 meter square. There is also a feature of nocturia. Nocturia is due to the loss of concentrating ability and increased osmotic load. The patient complains of tiredness and breathlessness. There is pruritus, anorexia, nausea, and vomiting. So there is raised blood urea and creatinine. There are features of hypertension. There is proteinuria, anemia. The disease is slowly progressive and the patient are asymptomatic until the GFR falls below 30. There is nocturia due to loss of concentrating ability and increasing osmotic load. There is tiredness, breathlessness, pruritus with anorexia, nausea, and vomiting. There is deep respiration that is related to the metabolic acidosis, muscular twitching, fits, drowsiness, and coma ensures. We have various investigations that could be done in case of chronic kidney disease or the chronic renal failure. The basic investigation that we have to go for is the urea and the creatinine level, checking for the urea and creatinine level, urine analysis and quantification of proteinuria, checking for the electrolytes, calcium phosphate, parathyroid hormone, albumin level, full blood count, lipids, glucose, renal ultrasound, hepatitis and HIV serology, and ECG. So there are various investigations that could be done. It includes urea and creatinine, urine analysis and quantification of proteinuria, electrolytes, calcium phosphate, parathyroid hormone, albuminuria, full blood count, renal ultrasound, hepatitis and HIV serology, and ECG. Now, how can we retard the progression of the chronic kidney disease? The progression can be retarded by plasma creatinine level. That is, if it is above 3.4 mg per dl, it causes progressive deterioration in the kidney function, irrespective of the etiology. We have to control the blood pressure, and in the diet, we have to restrict the proteins. So retarding the progression of CKD involves the plasma creatinine level above 3.4 mg per dl causes progressive deterioration of the kidney function irrespective of etiology. There is control of blood pressure, diet restriction of protein. How to manage the adverse effect of chronic kidney disease? So management of the adverse effect of the chronic kidney disease, we have to do the management of the anemia. We have to manage the fluid and electrolyte balances. We have to check for acidosis, infections, bleeding, renal osteodystrophy, myopathy, and other adverse effects. So for the management of adverse effect, we have to do the management of anemia. We have to do the fluid and electrolyte balances. We have to check for the acidosis, infections. We have to check the bleedings, renal osteodystrophy, myopathy, and the other adverse effects. Now, how to manage a case of chronic kidney disease? So management consists of correcting the anemia. The level of the anemia correlates with the severity of chronic renal failure. We have to find the causes and we have to manage by relative deficiency of erythropoietin. it has to be supplemented. There is diminished erythropoiesis due to the toxic effect of urania. There is reduced red blood cell survival, and there is increased blood loss due to capillary fragility. So there is increased blood loss, there is excessive RBC destruction, there is reduced intake and absorption. Therefore, iron supplementation is needed in such cases. Fluid electrolyte balance has to be managed for reducing the ability to concentrate urine. There is limitation of potassium intake, that is 70 millimole per day, and sodium intake, that is 100 millimole per day. We have to check the acidosis. The declining renal function is associated with metabolic acidosis. We have to give to the patient sodium bicarbonate supplements. We also have to check for the cardiovascular disease and lipids. Atherosclerosis is associated with usually hypertension. Vascular calcification develops in some cases with hypercholesterolemia. It is significant with proteinuria and increased triglyceride level. And we have to treat for these abnormalities. Now, next we come to the infection. Infection is the second most cause of death in dialysis patients, in the patients with chronic kidney disease. And we have cellular and humoral immunity that is impaired, and treatment of the cause has to be done. Bleeding tendencies. Platelet function is impaired and bleeding time is prolonged. So there is cutaneous ecchymosis and mucosal bleeds. Adequate dialysis corrects the bleeding tendencies. With renal osteodystrophy, it is the mixture of osteomalacia, hyperthyroid, bone disease, osteoporosis, and osteosclerosis. There is deficiency of alpha-1 hydroxylase enzyme, and parathyroidectomy can be done. In case of myopathy, generalized myopathy is due to the combination of poor nutrition, hyperparathyroidism, vitamin D deficiency, and disorders of electrolyte metabolism. There are other adverse effects, which includes sensory neuropathy, it is causing paresthesias. We have motor neuropathy that causes foot drop. Uremic autonomic neuropathy that causes delayed gastric emptying. Diarrhea and postural hypertension. There is gastrointestinal manifestation that include anorexia, nausea, and vomiting. Next, we have high incidence of peptic ulcers. There is depression. It is the most common in patient approaching renal replacement therapy. So this is all about chronic kidney disease. In the homework, you have to define the chronic kidney disease, and you have to write about the pathogenesis, clinical features, investigations, and management from your book. So this was all for today. In the next lecture, we will be discussing about nephrotic syndrome. So this session is powered by digital version 2.0, JAYOTI VIDYAPEETH Women's University. I hope you have understood this session properly. If you have any query, please mention in the comment box and I'll try to resolve. So this was all for today. Thank you very much.